You're welcome to my channel. Today I'll be addressing the steps involved in making accurate diagnosis of hypertension. It is one thing to measure the blood pressure accurately. It is another to make correct diagnosis of hypertension because of the possible risks involved. Who should be screened for hypertension? Anyone 18 years or older should be screened, please. And that should be done at every clinic appointment. Every year, please endeavor to have your blood pressure measured, even if it will be at the pharmacy. If there are risk factors for hypertension like positive family history, you are a male, black, you have sedentary lifestyle, you eat junk foods, you smoke, drink alcohol, you have diabetes mellitus, you have sleep apnea, then the measurement of your blood pressure should be done every 6 months. If you're visiting the clinic for the first time just to know whether you are hypertensive or not, usually that may not be the time that hypertension will be diagnosed. But there is no conclusion yet. If the BP is measured and is greater than 180 over 110 or greater than 180 over 120 millimeters of mercury, hypertension will be diagnosed right now. If the BP is greater than 200 over 120 millimeters of mercury, hypertensive urgency will be diagnosed right now. Also, the BP might not even be that scary as per value, might be greater than 160 over 100 or diastolic blood pressure is greater than 120 with signs of end organ damage. If that is the case, signs of end organ damage like left ventricular hypertrophy, fundoscopy giving papillary edema, there is hypertensive encephalopathy, renal system is shutting down. If that is in addition to high blood pressure, that is hypertensive emergency. In fact, there's a full presentation right here on that. Check my channel because you have to go to emergency room right now and intravenous antihypertensive agents will be used immediately, but the BP will not be crashed down. If there is diabetes mellitus in you already or you have renal disease and the BP is greater than 130 over 80, the doctor will make diagnosis of hypertension right now. If the BP is measured and systolic is greater than 140, while diastolic is below 90, isolated systolic hypertension will be diagnosed right now. But note this, in elderly patients, 75, 85, or 90 years old, with any value less than 150 over 90, he or she is not hypertensive. Let me give a typical example. 80 years old. Now, with me, the BP is 140 over 85. That is not hypertensive. Why? Because of the age. Okay, today, if the value of the blood pressure is not giving me the concern to make the diagnosis of hypertension today, just as we've gone through in the last 2 minutes, the previous slide, then I will do something different. Today, we are going to have all necessary investigations done. Today, we are going to take full history. Today, we are going to do full physical examination as it is related to cardiovascular system or hypertension generally. Then advice will be given as per home blood pressure monitoring and ambulatory blood pressure monitoring, depending on what I'm able to pick during the history, physical examination, and investigation. We may use office blood pressure monitoring if you cannot get any of these done on your own. Then I will advise that you come for the second visit by the next month. So 30 days after, please, let's see you again. Then we will review the laboratory results, the history, the physical examination, and whatever you have as home blood pressure monitoring values or ambulatory blood pressure monitoring values. We go over all of them. Now, what would the history include? The blood pressure in you, if you have been taking it before, the values, family history of hypertension, medications you are taking right now, target organ damage in case of hypertensive emergency. We'll rule out secondary causes like pheochromocytoma, Cushing syndrome, diabetes mellitus, renal damage, and so on. Social history, street drugs, smoking, marrying, job, any psychosocial stressor in your life, diet, sleep apnea. We'll go through all that. Then the physical examination will start with gross inspection. Look at you from head down to toe. Pay attention on cardiovascular and respiratory system, full examination, abdominal, fundoscopy, and full neuro examination. Today, we will order for chest x-ray, echo, depending on the clue I'm getting, ECG or EKG if you're in North America or Europe. Okay. Today, we will send you to lab, have an analysis done. If I suspect that I should have toxicology screening done, I'll do it. Electrolytes, complete blood count, renal function test with albumin creatinine ratio, blood sugar, clotting profile, fasting lipid, vanillin mandelic acid to rule out pheochromocytoma. There's a metazone suppression test in case of Cushing syndrome, atherosclerotic risk estimate. All will be done today. Okay, the patient is here for the second visit because we couldn't make the diagnosis of hypertension the first time, right? Now, let's check the blood pressure values. If it's greater than 130/80, and this person is already diagnosed with diabetes mellitus, or office blood pressure measurement today is greater than 140/90, then we are going to make the diagnosis of hypertension right away. Also, if home blood pressure monitoring is giving us value greater than 130/80, just as ambulatory blood pressure monitoring is also giving us the same, 130/80, then we're going to make the diagnosis of hypertension today. So, 4 scenarios here. Diagnosis of hypertension could be made today, though it's just the second visit. However, we have a phenomenon known as white coat hypertension. Here, the BP with a doctor will be very high. Will be greater than 130, 140, 150, 160/80, 90, or 100. But going through the record of home BP monitoring and ambulatory blood pressure monitoring, we are not finding a very high level of blood pressure compared to what has been peaked right now at the clinic. So we'll feel concerned. What's going on? Is lower than 130/80 outside the clinic, at home, or while walking around in the last 24 hours. But right now, before me, is pretty high. That is white coat hypertension. If the BP measured by me is within normal range, but the value brought from home is less than 130/80, then I may conclude that there's no hypertension. But I will do one thing before sending the patient away. Let me repeat, I will go through the history again. If there is associated cardiovascular problem or there's any renal problem somewhere in this patient and with other risk factors, then I must not let her or him have false impression that everything is fine. So I would tell him or her to have that ambulatory blood pressure monitoring or home-based blood pressure monitoring repeated. Okay, I will get that repeated. Remember, this is just second visit, so why am I in a haste to jump at a conclusion? No, get that repeated. Now, the patient is around, the BP has been measured, is within normal range. But remember, I've told the patient to go and repeat the ambulatory and home blood pressure monitoring. It's now greater than 130/80. Then something is wrong. That is marked hypertension. That could be pointing to maybe family stress, job issues, anxiety, or exhaustion. It's still the second visit, but no diagnosis. If I can't make diagnosis yet, I'm not going to end the interaction there. We'll ask the patient, him or her, to come back in one month. It depends on what is obtainable as a jurisdiction. Some will say 3 months or 1 to 3 months. I'll be okay with 1 month. In 1 month for the third visit. So it's not a crime if diagnosis is not made, at the end of the second visit. Just do everything. So diagnosis could not be made, either mild hypertension or whatever. Come back the third visit, please. Okay, the patient is here, the third visit. If no hypertension has been diagnosed after the end of the second visit, of course, that's the reason why we have the third visit, right? We will repeat the BP today. If the office BP is greater than 160/100, remember this is the third visit, then we'll make the diagnosis of hypertension right away. We'll then keep the record and start treatment, either from lifestyle modification and so on. That is the first scenario here. Second scenario on third visit will be if the BP is greater than 130/80 but less than 160/100, we will do nothing, okay? And we will check anyways. If this patient is having diabetes mellitus or renal failure, we will do something. If there are signs of end organ damage, we will do something. But if that is not the case, the BP is between 130 and 160, less than 160/100, we will do nothing more than counseling and then invite him or her for the fourth visit. And of course, the fifth visit might be possible if we're unable to conclude by the time we'll be rounding up during the fourth visit, and that will be 1 to 3 months apart. Okay, I hope the patient is not tired. He or she is back for fifth and sixth visit. If BP is averagely less than 130/80, then you can conclude that there is no hypertension. If the average of the BP is greater than 130/80 up to 140/90, you can make the full diagnosis of hypertension this time. If it is less than 130/80 millimeters of mercury, no hypertension is diagnosed, I repeat, but you have to continue annual checkup. As per the treatment, that will be another presentation entirely, but you can check my channel right here. I have a full presentation on the treatment of hypertension already published. Another one already published had been on the list of antihypertensive agents, and another one on correct selection of antihypertensive agents in different categories of people with hypertension. The goal is BP less than 130/80 in diabetes mellitus and most patients, 130 to 140/80 to 90 in some people, for example, the elderly, orthostatic hypotension, someone on many antihypertensive agents. So different people, different value of BP will be expected. Thanks for listening. Remember to share this very presentation because it is very, very important to make correct diagnosis of hypertension. Remember where I started from. If we make wrong diagnosis, if we label someone to be hypertensive when he or she is not, our medications will tilt the individual to hypotension, and that could lead to death. And if we miss the diagnosis of hypertension saying he or she is not hypertensive when he or she is actually hypertensive, then we'll be faced with complications of hypertension. And one of them is stroke. Remember to subscribe to my channel as well so that anytime I publish my presentations, you'll be able to get a copy immediately. I appreciate that.